Good afternoon, colleagues. Good morning to those of us who are on the other side of the continent. Thank you so much for making the time to join us on today's webinar. We're very excited that you were able to make the time. My name is Foyeke, and I work with USAID Nigeria, the Health Office of USAID Nigeria, as a program manager for social behavior change programs. Very honored to be able to open the webinar today. This webinar is jointly convened by two of USAID's flagship and global social behavior change awards, which is Breakthrough Action and Breakthrough Research. Both awards were uniquely designed to be able to advance SBC programming on one hand, which is a core mandate of Breakthrough Action, as well as SBC Research, which is the core mandate of Breakthrough Research. So you'll be learning quite a bit about both awards in the course of today's webinar. We will also be learning about one of the unique research undertakings that the Breakthrough Research Project has undertaken in Nigeria, which is the design and conduct of a behavioral sentinel survey. The survey is designed to track over a period of 3 years changes in ideational factors, or what we call determinants that influence the uptake and sustained practice of a range of behaviors, maternal child health, nutrition, family planning, and malaria behaviors. And it will track this among a cohort of women who have been exposed to Breakthrough Action Nigeria programming on social behavior change in Kebbi, Zamfara, and Sokoto. So the first phase of the BSS was completed in 2019. This is one of a series of webinars that is getting us through, would increase our knowledge first around the methodology that guided that first round of BSS. It would also expose us to some elements. So the BSS did generate a significant volume of useful program data that's not just helpful for designing or planning or adapting existing ongoing programs, but also to inform, program and investment decisions. So today, over the course of the next 1 hour, you will be guided by our survey presenters who would expose us to some of the findings from a detailed analysis of, the relationship between ideational variables and immunization outcomes. I would want to encourage you to please give us your complete attention, as there would be quite a lot of interesting findings to share. I would hand us over to our presenters, but we'll quickly introduce them to us before I do that. So we have 4 presenters on the webinar today. There's Dele Abegunde, who is the Chief of Party for Breakthrough Research in Nigeria. There's Shitu Abdul Aguye, who is one of the deputies for the Breakthrough Action Project in Nigeria. Emily White Johansson is the deputy for Breakthrough Research also in Nigeria, and Paul Hutchinson is one of the principal investigators on the Breakthrough Research BSS study, and he's from the Tulane University, which is one of the partners on the Breakthrough Research mechanism. So I would hand you over now to Dele. In the course of the webinar, please keep your microphones muted so that we don't distract others. And please drop your comments and questions in the chat box so you don't forget them. We would have a time at the end of the presentations to answer all of those questions. So over to you now, Dele.
Thank you very much, Foyeke. It's always a pleasure to have you present with us each time we come on. As Foyeke has introduced, this is perhaps the 5th in the series of breakthrough research webinars that we've been doing, and I want to thank you for those of you who have always been with us through the series. Thank you, and for those of you who are joining now, thank you. I think we will be introducing the other webinars that are coming on as we present so that you can remain with us. As we go on in this webinar, we want you to use the chat box to raise questions, raise your hands for questions. We desire a lot of discussions from you, questions and interrogation of the results. It kind of improves the robustness of the huge results that we are getting from the analysis that we are doing. Next slide, please. So as we go into this webinar, we will be introducing you more into what we are about, breakthrough research. Also, breakthrough action will be giving us a little bit of flavor of their activities in Nigeria. We will also be explaining what the behavioral sentinel surveillance survey is, which is a huge survey that breakthrough research is doing to back up breakthrough action. Also in the webinar, this webinar, we're focusing on routine immunization, how formative research informs the BSS survey, how we'll be introducing new ideation metrics that we have measured, and then we will be discussing key BSS findings related to immunization in this webinar. And of course, we will be discussing the implications of these findings to SBC programming in Nigeria. Finally, we will discuss with you the future work following these researches that we have been doing. Next slide, please. About breakthrough research, like Foyeke introduced us, it's a USAID flagship project for social and behavioral change, research and evaluation. It's a 5-year project which began in August 2017, and it's going to end in July 2022. Our activity started in January 2019, and Breakthrough Research Nigeria office was opened for business in September 2019, though a lot of work was going on before the office was established. We're in close collaboration with our sister project, Breakthrough Action, and other PIs, but Breakthrough Action is our major primal audience that we do the research to support evidence and information for their programming. Next slide, please.
So thank you, Foye. Thank you, Dele, for opening the session. It's a pleasure once again to be here to present on the immunization vaccination findings. In the next few slides, I'll just talk a bit about breakthrough action in Nigeria. Change project. Of the breakthrough action project in Nigeria is to increase the practice nutrition, family planning, and malaria. Just like breakthrough research, it's a 5-year project from 2017 to 2022. And we have 3 intermediate results. First is to improve individual and social determinants of health by addressing knowledge, attitudes, social and gender norms around the priority behaviors. Secondly, we're working to strengthen coordination, collaboration, and linkages between USAID, SBC, service delivery and commodity logistics programs in the intervention states. And thirdly, we are working to strengthen the capacity of governments, ministries, departments, and agencies at national and state level to provide oversight and coordination for SBC activities in Nigeria. Next slide. Now, there are 12 behaviors that cut across MNCH, FPRH nutrition that Breakthrough Action is working on. And many of you agree that it's hard to effectively message on 12, conduct SBC activities on 12 behaviors if you do not put them in a logical format that can be addressed. What you see here are the behaviors sort of grouped according to milestones that range from pre-pregnancy to ages 2 to 5 for the children. We also work with what we call life stages. The pregnancy milestone is pretty much life stage 1. Childbirth is life stage 2. 6 months to 5 years is about life stage 3, and pre-pregnancy falls within breakthrough actions life stage 4. And these are the buckets in which we use to address audiences at community level. Next slide. Breakthrough Action Nigeria uses the coordinated multi-channel approach for our interventions. There are 5 main approaches that we use. Under community mobilization, we have community social behavior change. These are our direct demand creation activities that involve compound meetings, community health dialogues with individuals and families, and these are where we issue referrals for services and also address knowledge of priority behaviors and benefits and things like that. Community capacity and sustainability activities. Here we work with WDCs and other structures in the community health ecosystem to facilitate community-directed learning and problem solving around the priority behaviors. There are mass media activities where we have the popular Bishirinku radio drama that airs every day of the week in the intervention states, Bauchi, Sokoto, and Kebbi, those 3 states for now. We also have accompanying sports and radio magazine programs that are also aired on mass media. The mobile digital approach is a cross-cutting approach. It supports all the other approaches that we use. Some of the things we do in mobile digital is mobile data collection. The mass media contents are hosted on Airtel 321, where people can access them even after they've aired on mass media. We also do activities around interactive voice response messaging for mobile curriculums for some of the community volunteers that work on the project. We have advocacy activities with religious, traditional, and opinion leaders. Here we work with these leaders through the social behavior change advocacy core groups to address social and gender norms around the priority behaviors. Finally, there's the provider behavior change activities where we work to influence provider behavior on malaria prevention and treatment guidelines and respectful maternal care. Some of the things we do under PBC are fishbowl discussions, OIC cluster meetings. We also engage with professional associations, and also we've carried out some behavioral economics activities around malaria RDT under the provider behavior change approach. Next slide. Breakthrough Action works in 11 states and FCT, as you will see on the map. The BSS study is being conducted in 2 integrated states, Kebbi and Sokoto, with 1 vertical malaria state as a state for comparison, as you will also see on the slide. Thank you. I'll hand over to the next speaker to continue with the presentation.
Thank you very much, Chitu, and also to you, Dele and Foye. So I'm Emily White-Johansson, the Deputy Project Director and Director of Research and Evaluation at Breakthrough Research in Nigeria. So I'll talk now about the Behavioral Sentinel Surveillance Survey, or what we call the BSS, both in general and then also our specific research results related to routine childhood immunization. So the main objective of the BSS was to assess the effectiveness of integrated versus malaria-only SBC programming on malaria, family planning, and maternal, newborn, and child health plus nutrition outcomes among pregnant women and women with a child under 2 years living in BA program areas within the 3 states in northwestern region. The BSS measures priority behavioral outcomes in the same way DHS does, across each of these health areas. But in addition, and importantly, it also measures psychosocial influences or ideations across cognitive, emotional, and social domains that are theorized as intermediate determinants of behavioral actions and decision-making that are targeted by SBC programs. So the psychosocial factors across each health area were developed based on the Kincaid theory of strategic communication and behavior change. This theory posits a pathway from exposure to communication activities, in this case, BA's mass media advocacy and community engagement strategies that Chitu just talked about, through 3 ideational domains and 9 ideational subdomains that is posited as leading to changes in both the intentions to undertake the behavior in the future and the behavioral action in itself. So survey questions included in the BSS were intended to measure as many of these domains as possible across all of the priority health behaviors. So if you figure that we have 12 core behaviors, as Shitu talked about, and 9 subdomains, that's a minimum of at least 100 questions just to get a comprehensive look at the drivers of all priority behaviors. In reality, we did have many more questions than that, but even then it wasn't as comprehensive as we would have liked, but we had a trade-off between being comprehensive and risking respondent fatigue that could jeopardize overall quality of the survey. The main study populations for the BSS were currently pregnant women and women with a child under the age of 2 years. These populations correspond to the main life stages focused on by BA, as Shitu also mentioned. And specifically, they focus on the priority 1,000-day window from pregnancy through the first 2 years of the child's life. We collected data in all 3 states, but again, the data are only representative of the BA program areas within these states and not the states themselves. We conducted the baseline survey in September 2019, and these are the results that I'll be presenting today. And we have plans for a midline survey later this year, but dependent on when COVID restrictions are lifted, and then an endline survey at the end of the project. The study design involves both cross-sectional and cohort components to provide estimates of prevalence of behaviors and ideations over time. We will use repeated cross-sections of women with a recent completed pregnancy at 3 points in time, the baseline, midline, and endline. And we'll also follow a cohort of women who were pregnant at the time of the baseline survey to document their 1,000-day window experience. There's a quasi-experimental component, as Shitu mentioned, in the sense that we're comparing geographies with integrated programming in Kebbi and Sokoto states with those with vertical malaria-only programming in Zamfara States. The sample size for the baseline survey included over 3,000 women who were pregnant at the time of the survey and another 3,000 women with a recent pregnancy that was based on a random sample taken. In the presentation today, we'll present both bivariate and multivariate analysis results. For the multivariate analysis, we present the predicted probabilities of an outcome occurring based on mixed effects logistic regression models, and those models are adjusted for ideational and socio-demographic variables that also take into account the complex survey design. The final baseline technical report is now publicly available, and it's on our website at the link listed here. It includes full details of the survey background and methods, as well as complete descriptive results with over 500 indicators reported by state. I encourage everyone to download the report, to look at it, to get a sense really of the breadth and richness of the data we've collected, not only for routine childhood immunization, but also across all other of these health areas, family planning, malaria, and other maternal, newborn, and child health areas. So as Delia and Shitu mentioned, Breakthrough Action, our sister project, conducted wide-ranging formative work during their first year on the ground that we really heavily drew upon in developing the survey questionnaire. Some of this work included literature reviews and their own qualitative interviews with women in these areas to assess in terms of routine childhood immunization, women's perceptions of vaccinations, vaccination fears, reasons for not taking their child to routine immunization, and that some of the results they found included fear of side effects, vaccine mistrust, facility distance, cost, and other reasons. And so all of this previous work from the literature reviews and from formative studies that BA prepared really helped us tremendously in shaping the questionnaire that we used for the baseline survey. And so for those not familiar with the Nigerian childhood immunization schedule, this slide provides an overview. And Nigeria considers a child to be fully immunized by his or her first birthday if they've received the following vaccines: BCG, 3 doses of DPT vaccine, 3 doses of polio vaccine, and measles vaccine. And so the fully vaccinated child, that is a main outcome that we're going to be analyzing throughout this, presenting upon throughout this webinar today. Now, just to say one thing about the innovative ideational metrics that have gone into this survey, you know, there are a lot of ideational metrics in the published literature related to family planning and malaria, but there's been much less published in the literature for other areas of maternal and child health, such as for pneumonia or diarrhea or pregnancy and childbirth. And it really is important to have this kind of information because in the theory of strategic communication and behavior change, ideational factors are so important and are the basis for investment in breakthrough action, both in Nigeria and globally. It provides not only the behavioral outcome, but potential reasons why we may be seeing low coverage or low service use. And it's important to test the underlying relationships between these ideational factors and behaviors according to this theory. But for vaccination, we use questions and adapted research based on the WHO vaccine hesitancy work that has taken place. And we adapted this for the northwestern Nigerian context. And the questionnaire was developed jointly with BA and with input from outside experts. And again, as I mentioned before, we had to ask a limited set of ideational questions across each health area, or we would have had a very long questionnaire. So questions were prioritized for inclusion based on their importance programmatically. So again, these are some of the examples of the vaccination ideational metrics that we included in our work. So for each health area, we tried to have at least one question for each specific ideational domain. For example, for knowledge, we asked at what age should a child go for her first routine vaccination? And then we coded the data for analysis as those provided the correct answers versus those that did not. For beliefs, we had questions such as, in your opinion, how effective are childhood vaccines? And Likert scale statements, including vaccines have chemicals that can be dangerous to a child's health. And we coded responses as strongly agree with the statement, somewhat agree, somewhat disagree, strongly disagree, or don't know. We also included questions related to emotional and social domains, including self-efficacy or confidence in performing the promoted behavior, social influences on decision-making, social norms, and also behavioral intentions. So I'll present the key findings according to SBC program priorities, and this includes behavioral patterns first. How frequently do respondents practice the promoted behavior at this baseline period that we've been measuring? What are key behavioral patterns by geography or socio-demographic characteristic? Knowledge and beliefs. Are respondents aware of the promoted health behavior, such as how to prevent disease? Are certain beliefs held by respondents that could impede progress? Barriers. How do respondents view health services in their communities? What are the main reasons for choosing certain treatment locations or for not using services at all? Social influence and decision-making. How do health decisions get made in a household? Who mainly influences a woman's healthcare practices and decisions? And at the end, we bring all of this information together in terms of knowledge, beliefs, social norms, social influence, into regression models to look at these ideational relationships with the behaviors to answer questions such as how important are the individual components of behavioral change frameworks? What ideations should SBC programs be targeting to maximize impact? So as you'll see from this chart and the next slide, there were extremely low rates of children receiving all basic vaccinations by their first birthday, as we know also from the Nigeria DHS 2018, or having a fully vaccinated child. Yet, just to reiterate that even within this poor state, there was variability in this percentage by wealth and maternal education. And this slide shows maps of these maps of these outcomes by LGA within the study area. And you'll see in the lower middle part, the fully vaccinated rates had very extremely low rates across the entire study area. And I've posted this map next to maps from other MNCH areas just to show that it is extremely low rates for immunization compared to other areas where there was more variability by LGA within the study area. This is just coverage for routine vaccination for each specific type. You'll see 27% of children aged 12 to 23 months received BCG vaccine by their first birthday, compared to 10% receiving DPT3, vaccination, and again, only 6% of children across the study area, aged 12 to 23 months, received all basic vaccinations by his or her first birthday. We found low knowledge of vaccination timing. When we asked at what age should a child be taken for his or her first routine vaccination, only 1/4 knew that a child should get their first routine vaccination at birth. Half explicitly stated they don't know when a child should get their first routine vaccination, while many others provided a different response. Vaccine myths also persist across the study area. When we asked, in your opinion, how effective are childhood vaccines, more than 1/4 of respondents believe vaccines are not effective or were unsure about their effectiveness. And more than half believed or were unsure if vaccines have chemicals that are dangerous to a child's health. And nearly half didn't think or were unsure again that it's easy for mothers in my community to take children for routine immunizations. In terms of barriers, we asked women who did not vaccinate their child about reasons for non-use of these services. And the most commonly cited reason was spousal opposition. 1/3 of women cited spousal opposition as a reason for not vaccinating their child. However, we should mention we did not ask further questions in the survey about the nature or reasons for this opposition by their husbands, which is an important area for future work for informing SBC programs. Other main barriers that were cited by women for not taking their child for vaccination included facility problems such as distance or cost, as well as vaccine concerns, including fear of needles and side effects. When we asked women who besides themselves may influence their decision to get their child vaccinated, the vast majority of women reported their spouse or husband, again underscoring the outsized influence of men on vaccination decisions in these communities. And even more importantly, from multivariate regression analysis, we see that spousal support had a significant relationship with uptake of DPT3 and measles vaccination. Women whose spouses supported their decision were 1.6 and 1.4 times more likely to have their child get DPT3 and measles vaccine, respectively. We also found that actually the health provider support or influence was significantly associated with a child receiving all basic vaccinations. Of course, we saw on the earlier slide that very few women mentioned health workers as influencing their vaccination decisions. However, from regression analysis, when women had health worker support, they were more likely to get a child vaccinated. Although a word of caution on this result, this could be the result of a reverse causation such that women who take their child to get vaccinated, they must see a health worker and therefore cite their support. So now we present the results of other significant associations we found between psychosocial factors or ideations and routine childhood immunization uptake through regression analysis. This slide shows the importance of vaccine beliefs on DPT3 and measles immunization in children. Women who believed illnesses that vaccines prevent are severe were 2.6 times as likely to have a child get measles vaccine or 3 doses of DPT vaccine. Women who believe that most people in her community trust immunization health workers were over 3 times as likely to have a child get 3 doses of DPT vaccine. We also found that a woman's ANC attendance 4 or more times during her last pregnancy was significantly associated with having a fully vaccinated child. Women who attended ANC 4 or more times were more than twice as likely to have a fully vaccinated child than those who did not. So is ANC a gateway moment, or could it be a gateway moment for these other downstream MNCH behaviors? You know, this slide shows that there is a significant association between ANC attendance and these other important maternal child health behaviors, including immunization. And so more work's really needed to investigate this relationship and understand how to enhance ANC for this potential multiplier effect. Now I'll turn the presentation back to Shitu, who will discuss the program implications of these findings and how BA will use these results for program learning and adaption.
Thank you, Emily. Next slide. So one key finding that has come out from this study is the very low and inequitable routine immunization rates. Nearly all study areas had less than 10% of children fully vaccinated. And then despite low rates, the wealthier quintile were 8 times more likely to have a fully vaccinated child. Now, I was looking at this specific finding and I thought about some of the areas where Breakthrough Action implements the program. While the communities are not necessarily homogeneous, they're quite similar really across the various states in terms of really rural or semi-urban populations. And within these communities, the wealthy households are dispersed among the less wealthy ones in these communities. So it's not as if the wealthy households are like clustered in one region and separate from those are not so well to do. So I think one question we need to further ask really to dig deeper into the data is what makes the wealthier households more likely to vaccinate their children? We've seen the effect of education already in these results, but what else could it be? Is it increased risk perception? Is it based on ability to pay for services? Is it more receptive to the messages? I mean, we need to really dig a bit deeper to know what the issues are beyond just programming at multiple levels, because really the projects are implemented in similar settings. Secondly, we need to focus on the role of men in vaccination decisions. This is a key finding outcome from this study. Spousal position was most cited as the reason for not vaccinating children. And we need to really look for innovative ways to target men more with SBC activities. And I do agree that more research is needed to understand the male ideations and behaviors around vaccination. Next slide. Previous slide, please. Yeah, thank you. Next slide. Now, the importance of health services, quality and trusted providers also came out as a finding from this study. Women with health worker support were more likely to fully vaccinate their children. And then trust in immunization workers was also associated with DP3 uptake. Now, if I couple this with the spousal support finding from the previous slide, I begin to think that is there possibility of exploring SBC approaches that facilitate women or families having some form of support, peer support or some other kind of support to ensure that, to help them facilitate decisions around having their children immunized. I just wonder if, for example, women have health bodies or people they're paired with that they support each other to access services that would help to improve the uptake of immunization services. There are problems at the health facility, distance closure costs that still remain, and we need to address those perceived and actual problems that exist at the health facility level. We need to tailor SBC messaging to improve vaccine knowledge and dispel myths. Unfortunately, a lot of the vaccine preventable diseases are not as glaring in terms of seeing them on a day-to-day basis in the community. So a lot of people may not see the need to take an injection for what is not really a visible problem. So SBC programs may need to emphasize more on the severity of vaccine preventable diseases, and also talk about how the efficacy of the vaccines that are available. Ensure women know when, where, and how many times the child should get vaccinated. This was also a key finding. A lot of women do not know when their children should get vaccinated. In terms of programming, I was thinking of something we're doing currently on Breakthrough Action, where we're having, where we're producing songs that we call Abishirunku songs. These are small 1 minute, 2 minute songs that emphasize certain behaviors that are played as interludes between radio programs in the states where we work. And I think there may be an opportunity for us to probably develop a song around the timing of vaccinations in a way that is catchy and have people and have provides a reminder for audiences who hear the song on radio and even during community level activities. We also need to dispel misperceptions about that vaccines are dangerous to children's health and have side effects. The side effects of vaccines are real. A lot of women, families are discouraged by side effects. And I'm sure you recall the slide where DPT was like 10%, DPT-3 was like 10%, which was like the lowest for any of the vaccinations. So we need to be very proactive in addressing issues around side effects and the misperception that vaccines are dangerous for children. There are still a lot of norms that affect vaccination and also beliefs that are not supportive of vaccination. And these are largely held by men, some of them who oppose their spouses from taking their kids for vaccination. We continue to engage with religious leaders, community leaders through the SBC ACGs, the social behavior change advocacy core groups in the states where we work to ensure that we address these norms and beliefs among men, among community members and families to reduce those barriers to vaccination in the various communities. Next slide. Thank you. Back to Emily. Odile.
Thank you very much, Shitu and Emily, for those discussions that you have started to stimulate in the presentation. So having done this, what are the next steps in our analysis of the huge volume of data that we have obtained from the field? First of all, we'll continue to conduct BSS analysis to inform SPC programming and program adaptation and scale up for BA and other IPs that might have some interest in what our data tells concerning their program. We have advanced in this, and this webinar is part of further analysis following the initial descriptive analysis that was done in the huge reports that you are encouraged to download from our site. We are already preparing manuscripts for publication, and research briefs have been prepared to share with everyone in disseminating the results widely. We encourage you also to share these research briefs to organizations and individuals that you might consider should have interest in some of these research briefs. I think we have close to 10 or so around there about research briefs at the moment. Our plan is advanced on the midline survey. We need to underscore here that as we are doing this survey, it's a longitudinal study in itself. There's a midline and there's an endline that is done along with breakthrough action programming. So the midline, bearing COVID, we should have started the midline by now, but we just delay a bit to see when we can hit the field, when it's appropriate for us to go back to the field to conduct the midline survey. We'll present the BSS results by specific areas like immunization. We'll be presenting on malaria also, so as to generally inform all the thematic areas in health and in our webinar series. Next slide, please. These webinar events started in June. You will see the webinars that we have delivered so far. We are in August 20. At this time, we're doing vaccination. The next one will be this sick child care seeking and treatment behaviors, which we encourage all of you again to log on as you have done today to listen to and interrogate results. Following that will be the malaria webinar. I think this should be huge to interest everyone in the health field, which will be in September 17. The family planning webinar will be in September 30, and then an overarching theme, which is inequalities in health behaviors and other factors that we have obtained in our data will be discussed in October 7. This will also express how inequality may impact on the outcome of the programming that not only BA is doing, but also other IPs that have programs in other thematic areas. Next slide, please. Regarding future works and significance, BSS baseline results are a first step for assessing the effectiveness and cost benefit of integrated versus malaria-only SBC programs in Nigeria. It's a huge data and it's a first step. It highlights the ideations and behaviors during this baseline period to inform SBC program and scale-up and adaptation. And it presents new additional metrics across maternal, newborn, child health, and nutrition, including family planning areas, and quantify their relationship with behavioral outcomes to test behavioral change theories that inform programming to change behaviors positively to increase demand for care. It links BSS results with routine program data or health facility results. That's one of the future work that we're doing. We're looking at another sister IP that may have data, facility data that we can link our own individual supply data with to examine the impact of supply and the demand side factors on service use. Next slide, please. Now, thank you for listening to us. The project team is really huge and expansive. We have Paul Hutchinson, who is a lead PI from University of Tulane, and Paul Hewitt of Population Council is a co-PI on this breakthrough research project. Emily Y. Johansson, BR Nigeria, also linked with Tulane University. We have Elizabeth Omoluabi and Akane Akinyemi, a professor at University of Ife from CRED. CRED is the organization that did the field work, the data gathering in a very scientific manner using high tech to collect the data. One reason why the data has a huge validity to it, even at analysis. And I'm yours sincerely, Dele Abegunde, Breakthrough Research Nigeria, and we have Dominic Mikas, Tulane University. Udo Chisholm is a Breakthrough Research Coordinator, and Stella Babalala, a professor in Johns Hopkins University. We'd like to acknowledge Ian Tweedy, the project director from Breakthrough Action Nigeria, and Matthew Oko, Breakthrough Action Nigeria. These are colleagues of FITU that has presented with us today. So we have Tulane University, we had RED, we have Population Council, we have Breakthrough Research and Breakthrough Action, and John Hopkins University are all organizations linked to this research. One reason why it's a high-level research with the results that are coming. We also want to thank USAID for funding this project. Next slide, please. So I want to thank every one of you for coming. We look to see you 2 weeks' time when we'll be presenting the 6th child webinar. We want you to interrogate our results. We also want you to continue the discussions by email on our web, and we'll be glad to respond to some of your questions. Download the report, and also when this webinar slides will be sent. So at this stage, I want to hand you over to Sherry Hutchinson and Anaba Udochizo, who will organize the question and answer time for us. Once again, thank you all for your attention and your attendance. Udo, Sherry.
Thank you, Dele. Appreciate that introduction. So we have a number of questions to go through. And so I'll start off with one, how did the vaccination rate associate with postpartum family planning, as I can see on the topic of the research?
How did we vaccination rates? We postpartum family planning was not brought into our model as a predictor of vaccination rates. So we could look separately at that to see how they could be correlated, but we didn't actually assess the postpartum family planning as a predictor of vaccination rates. But we'd be happy to look at that.
Okay. And then for areas where CHEWs predominantly attend to births, there may be need to build capacity of CHEWs with SBS messaging to improve vaccination, targeting the category of women who prefer to give birth at home. And that's just a to put out there. Oh, and for home births, do we have information on coercion by birth attendants or CHWs to go for first-time vaccination, especially among the low strata women?
We brought A and C attendants into our model because we were particularly interested in that. We didn't bring whether there was a facility delivery or home birth into the model, but clearly that could be related to uptake of vaccinations. It's something that we can look at by stratifying facility versus home birth. And in terms of the community health worker, I don't know, Shitu, if you want to talk to that about, I mean, you have community volunteers who are doing this messaging at the household visits. So I think maybe speaking about that would address the previous question too.
Sorry, I didn't actually get the previous question, but
about engaging CHEWs or community health workers to help raise vaccination rates in the poorest areas. I believe that was it.
yeah, so Breakthrough Action works with community volunteers already in this intervention states, LGAs and wards, and they're the ones who conduct the community SBC activities, really going house to house, carrying out dialogue sessions through compound meetings, community health dialogues, raising knowledge and addressing benefits, and also dispelling myths around vaccination, issuing referrals as well to children who have not had their full immunizations. And these are some of the ways that we increase the uptake of vaccinations in the communities where we work.
Okay, and then considering the huge variation in health and immunization indices of the northern states and southern states of Nigeria, What will be the program implementation of our sister states in southern Nigeria, for example, southeast, south, and southwest?
Yeah, I mean, there are very different issues that are going on in northwestern Nigeria versus the south. So you may also want to bring in different types of vaccine hesitancy metrics if you were to do the same type of survey into the south. I'm not, of course, you could ask some of the same questions about who influences decisions and perceptions of vaccines and norms, which could be applicable, but you may want to even ask different questions because it seems to me that the context is so different in the Northwest versus the South. But Shiti, BA is working in a lot more states than we are, so I don't know if you want to speak to that.
I think if from an SBC perspective, you really need to contextualize your interventions, and a lot of those, some of the norms that drive behaviors in the North may differ from the Southwest and South-South and other regions of Nigeria. So while, I mean, some principles or some interventions may be generic across the country, to really understand the context better and really develop appropriate interventions, you need to really have separate studies for those areas to understand what the norms and issues are, particularly those cultural ones in those specific regions.
And Shiti,
absolutely, if I may.
Yeah.
If I may chip in here, from decades, the context has really been different between the South and the North in Nigeria. And although much investment has gone into improving the situation in northern Nigeria, the results here obviously cannot be translated to the southern part of Nigeria, where comparatively the immunization rates are, even routine immunization rates are much higher than in the northern region, particularly in the northwestern region of the country where the rates are lowest. So I agree with Shitu's deposition that the SBC programming must also be studied to back up programming in the southern part of the country, particularly how this behavioral norm pans out, the degree of to which it affects the behavior, as Emily presented in the multivariate analysis, will be much different in the southern part of the country. Over.
And then, why was the research restricted to these geographical areas?
I can speak to that. I mean, BA works in 11 states, or it's recently expanded, but really we wanted, the main aim of our study is to assess integrated versus malaria-only vertical SBC programming. And so we wanted to exploit the natural variation in breakthrough actions project implementation. And so in the northwest corner, where the states are more similar, there were 2 states that were doing integrated SBC programming and 1 state, Zamfara, that was doing malaria only. And so it's really not set up to be an evaluation of BA as a whole, but really to assess this question. And now we're presenting baseline results. And then of course, also for, funding issues, logistical issues, it made sense. Are there other questions? Hello.
Sorry. Did you explore in a more qualitative way why men were so averse to vaccination? Any relationship to larger social cultural conversations about vaccination safety and efficacy?
We have not done that as part of this quantitative BSS survey. There will be, we do have breakthrough research as a whole has a mixed methods portfolio with some qualitative studies that will be, again, looking at this integrated versus malaria only, and through their integrated questionings and some of the qualitative, some of this may come up. But I wonder, she too has also looked at this qualitatively during your formative work period for breakthrough action.
Yeah, we didn't explore this specifically around spousal male spousal opposition to vaccination actually during that study. But maybe for future work in other states, it's maybe an avenue we can explore also to based on its finding from the BSS.
And then it might be the same response, but a follow-up is, is the spousal influence related to cost to accessing care? DPT-3 requires 3 separate visits to there, for example. So wondering if this may be related to distance to the health facility as well.
Yeah, I mean, we found for reasons for non-use or non-uptake of routine childhood immunizations, it was a whole host of reasons that drove these extremely low rates from, spousal influence and social influence, health facility concerns, and then also vaccine concerns. And so it really, as Shitu said, takes a whole holistic approach to address this. But of course, for getting 3 doses of DPT vaccine, there are probably facility distance cost issues too. That's all we can, I guess, really say from the data. Shitu, do you have more to add?
No, that's fine. Nothing to add to that.
No.
On the programmatic side, have you looked at how findings from the RCT on group A and C, JHU, can link with these findings around continuum of care interventions? For example, linking group A and C with a type of group immunization, etc. The G, A, and C findings are now in the first stages of being implemented in Nasarawa, Kaduna, and Kano so far.
Shitu, do you want to talk about some of the ways you're looking at A and C care?
Yeah, I am aware of some of the group A and C pilots that were conducted in the country some years ago. I'm not familiar with this specific GHU study, but it's something we'll probably should also probably look into to see what learnings can be applicable to our SBC interventions in Nigeria and the states where we work.
And the next one is, how is the post-COVID-19 area, the new normal, affect the implementation of this research? And they're wondering, another one was, how will be accounted for with the midline?
Well, the midline right now is delayed really until some of the COVID restrictions are lifted. I mean, we have to not only get approval from USAID and others to go forward, but also IRB approval. And so we don't know. And in addition, the BA programs have not been also taking a pause during this period. So if we did a midline, we need to also allow ample time for the BA programs to be running again in order to make it meaningful and not really just a second baseline survey. So it has had a major impact. We are now planning maybe for early next year to have the midline go through, and we're putting together protocols if we can get IRB approval for COVID mitigation strategies such as using PPE, keeping distance, etc. But yeah, it's had a major impact, and we are still talking about when and how the midline can be conducted.
And the effect on the variables during the midline, possibly?
Yeah, I think we'd want to, as much as possible, keep the same questions. I guess there could be potential for adding questions on COVID, but I think what we're really, I think the variables will probably remain mostly the same, but there's potential for adding questions related to COVID if needed.
And another one, we have a few more if we want to take a few more minutes to respond to all of them. Can the level of education by wealthiest quintile be attributed to positive vaccination rates?
We included, so we adjusted our models for socio-demographic characteristics, including wealth and education separately. So we looked at the independent effects of education and wealth, and I believe we didn't present these, but I believe also saw a relationship there. But of course, education and wealth obviously can go hand in hand too. But we did look at the independent effects of those socio-demographics in the model.
Were there findings on why women weren't attending ANC where from your results show that attendance seems to be an opportunity to improve vaccination rates?
We don't know why women were or were not attending ANC, but we did find that just ANC attendance for more times was associated with improved vaccination rates. Now, of course, it doesn't mean that ANC attendance led to those. It could be that there's something unobservable about health behaviors that we didn't measure among women who go to ANC that would also be prone then to also having their children vaccinated and doing all these other healthy behaviors. But all we can say is that we found a statistical association in these data relating ANC to immunization. I think if you want to answer these why or how questions, you'd have to do a bit more qualitative research on that.
And then the last one, is there any data available on vaccine injury in the states of focus? Is there any justification for the high level of fear around vaccine efficacy?
Is that related to fear of needles? Yeah, I don't know. I mean, obviously, and maybe she too, or Debbie can speak more to this, there are lots of myths because of polio campaigns there, or, lots of beliefs in that northern region. I don't know about vaccine injury per se. She too, or Debbie, do you know?
Well, I'm not sure, but I think, with vaccines, you're preventing things that have not occurred, and a lot of populations, lay people may not necessarily see the cause and effects of vaccination preventing something that is not visible. So I don't know, that may cast doubts about issues around the efficacy or the usefulness of the vaccine. But I mean, this is just me trying to understand what's behind that finding. But we'll probably need to do some more qualitative, like Emily has mentioned, to understand some of these things a bit better.
Okay. And that is the last question.
Can I just say, I did see a question in the chat box about how it was something to the effect of how our estimates differed from DHS or showed something different. And just to say that actually with the recent 2018 Nigeria DHS, our estimates are aligned actually with them, and for the most part falls within confidence intervals of what is shown for those states. Of course, there's differences in how we've sampled and also that we're not representative at the state level, but for the most part, we've measured these indicators in the same way. We've tabulated them in the same way as DHS. So, and they do actually are quite aligned actually. Thank you.
Okay. Okay. Sherry, that was the last question, I suppose.
Correct.
Okay. All right. So I guess that sort of safely brings us to the end of the webinar. I think the questions, many of the questions that were targeted at finding out qualitatively are things that, are potentially explorable with other types of breakthrough research. Qualitative assessments that are going on. This was completely quantitative. And I think the question of vaccine injury was particularly interesting because I think like Dr. Shitu did say, many people, vaccine preventable diseases is what you're trying to, avoid when you give a child a vaccine. And oftentimes the child may present with side effects, and without the appropriate education around what to expect when a child gets vaccinated, and then the child gets a fever as a result of that vaccination when he didn't have a fever prior to the vaccination, and you're looking at low literacy groups, some of those things could potentially, be the reasons why people feel like, there's something to worry about the efficacy, and that's just one of several reasons. So thank you so very much for sticking through till the end. We completely appreciate that you took the time. The questions were very compelling and thought-provoking. Thanks for your active participation and engagement and your comments and questions. If you haven't, please take the time to click on the link that Sherry shared to download the full report, and you can get a lot more from that. You could also, keep a date with us with the future webinars so that you also get to learn about other priority health areas. Hoping that today you've learned a thing or two that are new, or at least relearned something that you knew before, or unlearned something that you thought you knew, but clearly the evidence is telling us the opposite. So thank you again for staying till the end. We hope to see you on September the 3rd on behalf of the conveners, the presenters, USAID, my colleagues. Thanking you for staying through to the end, and have a pleasant evening or morning, depending on what part of the world you're joining from. Over.